Goodbye Acre, welcome Seeker. 가슴에 자신감을 심어드리는 라이안성형외과 원장 최상훈입니다. 오늘은 상파울루 대학의 유명하시고 저명하신 문호주 교수님을 모시고 가슴 성형의 트렌드와 최신 동향에 대해서 알아볼 예정입니다. So you mentioned about fat grafting at the medial side of your breast. So I saw your wonder figures based on breast cleavage units that were in the article, and I brought two of them. Can you explain to the viewers?
Sure, of course.
교수님께서 최근에 이제 PRS 저널이라고 해서 미국에서 가장 유명한 저널에 논문을 몇 개 실으셨는데 그 중에 하나가 가슴골의 지방 이식을 어떻게 하면 좋을지 최적의 아웃컴을 위해서 도식화된 사진이 있습니다. For the viewers, we block the nipple.
Yeah, of course. Yeah. The principle of hybrid surgery are very simple. Basically, we use the same landmarks that we normally use in any kind of breast augmentation. And briefly, we have the medial limit and the lateral limit of the implant pocket. In my practice, I use the footprint of the implant or the sizer in order to create a template. So I put the dome of the sizer of the implant close to the nipple complex. So with this template, we can calculate approximately the future IMF and the superior limit of the pocket. If the size of the template is larger than the footprint of the breast, maybe you have to lower the EMF. This happened in less than 10% of my cases. But the most important in terms of markings is to calculate the zones of fat grafting. If you have the inferior limit of the template, the future position of the IMF, on the upper side you have the superior breast line, as you can see here. And if you have the position of the superior breast line, you can plane the zone 1 of fat grafting. Normally, zone 1 of fat grafting, it's a crescent shape close to the implant pocket. And after the zone 1, on the upper side, we have the zone 2. It's also a crescent shape, but it's a transition zone between the zone 1 and the infraclavicular area. So if you have these two zones and you have more homogeneous transition between the implant area and the area with no implant. So if you have this homogeneous cleavage, you will not have any step and any identification of the implant limits on the upper part. And then we move to the medial aspect of the breast. I think it's one of the most critical areas because the great part of palpability and rippling that we observe after a breast augmentation happens on the upper medial aspect of the breast, especially when the patient does this position and you can see a lot of ripples close to the skin in this area. And the second point, as I mentioned before, is the distance between the two breasts. The beauty of breast augmentation is to have an adequate distance between the two breasts. If you have a large intermammary distance, this is not good in terms of aesthetic result. Otherwise, if you have a very close distance or very shorter intermammary distance, it's a unnatural result. In my practice and looking for the Brazilian women, 1.5 to 2 centimeters is okay. And you can achieve this distance using the implant and the fat graft. So on zone 3, it's a crescent shape that started at zone 2 and zone 1 until to the IMF on the inferior medial quadrants. And with this area of fat grafting, we can camouflage the implant surface and avoid rippling and avoid palpability on the medial aspect of the breast, as well as the reduction of the intermammary distance, zone 1, zone 2, and zone 3.
Oh, thank you for your wonderful explanation. Oh, I have another figure. That was the next figure of your article. Subdivide the zone 3 into A, B, C.
Yeah.
Yeah, so a lot of people will be wondering, what is this? So
This is very interesting because we have zone 1, a crescent shape, upper pole. Zone 2, it's a transition between the zone 1 and the infraclavicular area. And on the medial aspect of the breast, we have the zone 3. Depending on the anatomy of the patient and the position of the breast, we can put more or less fat into the zone 3. So I divide the zone 3 in 3 subtypes, zone 3A, B, and C. If you take a look to the patients that have a nice distance in the pre-op analysis, a nice and adequate distance between two breasts, maybe you do not need a lot of fat because the distance is already good. So fat grafting in this area is just to camouflage the medial limits of the implant. But sometimes we have a patient that have a wider intermammary distance, and besides the camouflage of the medial aspect of the implant, we have to reduce this distance, and then we have to use the zone B, zone 2B, and zone 3C. Zone 3, it's one of the zones that we can indicate independently of the pinch test.
oh, yes.
Basically, with a pinch test less than 2 centimeters, for me, it's subfacial plus hybrid. But sometimes we have some patients that have a pinch test of 4 or 5 centimeters, so it's not an indication for hybrid. But if you analyze it with care, the medial aspect of the breast, and the patient has a larger intermammary distance, you can indicate fat grafting
Yes.
Independently of the pinch test, because you can reduce the intermammary distance using a smaller implants, as I mentioned before.
Yes, I think the intermammary distance is the critical factor of doing hybrid augmentation.
Yeah.
So there are a lot of concerns among the patients in Korea, since a lot of doctors criticize fat graft. So is there any advice? I read your articles regarding with fat graft and like screening breast cancer in other articles, and can you give a short explanation?
Yeah,
How this
it's I think lipofilling to the breast is technical dependent. If you have a good technique and you work with a lower pressure and small cannulas, and you have some measures to purify the fat, I think in my experience the local complications very low.
Yes.
And are quite similar to the same alterations that we observe in a normal mastopexy or reduction mammoplasty.
Yes.
But in the great part of the cases, and great part of the cases for me, it's 95-97% of the cases we don't have any significant complications. Something between 3 to 5% we can observe small lumps, calcifications, and small fat necrosis. And the great part are asymptomatic. Some cases we observe some alterations in the mammograms or in ultrasound that they are easy recognized by the radiologist. So if you have a good technique, if you work with medium volumes implants, and you observe the limits of fat grafting, the results are very predictable with acceptable complication rates. I think the worst situation is when you put a lot of fat grafting and you use a large implants. It's one force against another.
Yes.
So you have the volume of the fat grafting and you have the volume of the implant, and these two forces together, you increase the pressure inside of the tissue.
Yes.
And sometimes you have problems in terms of fat intake. So if you pay attention to the good technique, the results are good and predictable.
Koreans have a strong interest in dual plane techniques, with many believing that dual plane approach is better than fascial plane. For me, I prefer fascial plane. Any comment about this?
Yeah, it's my preference. Dual plane, it's not so common in Brazil, but I think what happened in all of the techniques that we have in plastic surgery, we have indications. In my practice, in my world, I think premuscular pockets works very well in almost 90% of the patients. And I indicate the subfacial just because it's easy, it's less aggressive, you have a fast recovery, you protect the muscle for future reoperations, and I think it's the possibility to have less morbidity to a procedure that it's in our common practice. In this situation that we have a pinch test less than 2 centimeters, I think fascia has some limitations. So the possibility to indicate fat grafting in order to replace the muscular flap and camouflage the limits of the implant. In the situation where the patient doesn't have an adequate donor site, very thin patients, or in the situation where the patient refuses an extra surgery, maybe the patient has some cost limitations because it's a liposuction.
Yes.
In Brazil, we have a lot of surgeons that they do surgeries in hospitals, so you have an extra cost to perform even a small liposuction. So if you don't have donor site, or if you have cost limitations, or just because the patient doesn't want to manipulate other part of their bodies, I think it's the good indication for the dual plane techniques. In my experience, it represents less than 10% of the cases.
Well, this is almost kind of the same question. Some doctors in Korea say that fascial plane affects breastfeeding later on and also can affect screening cancer. So I think we use both fascial plane, and I have a lot of comments about that, but can I hear some comments about that from you?
Yeah, breastfeeding, I think it's well studied in the literature, and there is no relationship between breast augmentation and any impairment for future breastfeeding. Especially if you like inframammary approach and transaxillary approach, you don't have any disturb or any impeachment into the milk ductus and the connection between the glandular tissue and the nipple. Maybe it depends of the technique, and some surgeons like the parallel approach. In the past, we have a technique that was described by Dr. Pitangui. It was the transareolar approach. Maybe in this specific situation, you have some problems in terms of breastfeeding. But working with the subfacial pocket and using the inframammary approach, and especially the transaxillary, you have any connection or any problems in terms of the connection between the glandular tissue and the nipple. So breastfeeding is preserved. And the second question is related to breast cancer screening. I think with the technologies that we have nowadays, and especially high quality of digital mammogram, and also with high quality ultrasound, the widespread of MRI in a lot of centers, especially in a big city like Seoul, I think the breast cancer screening is not a big issue.
Yes.
In my experience, in 90% of the patients with a good mammogram and a good ultrasound, you can see almost 100% of the breast tissue with no question, with no doubt. In less than 10% of the cases, maybe it depends of the anatomy, it depends of the volume of the implant, and if the radiologists have any question or doubt about the results of the mammogram and ultrasound, they can add the MRI to the screening.
Yes.
And with a good MRI, you can see 100% of the breast tissue with no problem.